Okay, it's all yours.
Okay, good morning. I am going to share my screen. First, I just want to make sure that everyone can see my screen at this point. Can everyone see my screen?
Yes.
Wonderful. Well, good morning. My name is Chelsea Swink. I am an RN and a certified hospice and palliative nurse. As Liz was sharing, I am the Director of Nursing and Clinical Services at the Northern Virginia branch of JSSA Hospice. I'll share a little bit about when we opened our doors and who JSSA is. That's partly why this presentation is titled the way that it is. Today, I'm going to be presenting on what hospice, the hospice benefit looks like, but also how JSSA does that best here in Northern Virginia. At the end, I'm going to share a bit about how you could get involved with our hospice services, not as a patient per se, although you may know someone who could benefit from our services, but truly as a volunteer, if you felt that you wanted to help us out to continue the good work that's being done in our community. So just at the top, I wanted to introduce myself a bit. I have been a nurse for 8 years with a focus in hospice for the last 6 years. I did earn my CHIPN, the CHPN at the end of my name. That is a certification in 2025 that I earned. That was last year. So I've been with JSSA for close to 2 years. Proud to lead this hospice team in Northern Virginia. And we did open our doors January the 5th. So just over a month ago. We already have a census and we're already caring for patients, so we're very proud of that. The other individuals on the screen that you see, this is by no means an exhaustive list of who all is working at JSSA, but some of the individuals who are working closely with our Northern Virginia branch. So Dr. Sheila Chen is our medical director at the top there. Dr. Deepal Daria is our other medical director. Lizzie Horton is our executive director over hospice. I myself am there. And then Susan Augusty is our volunteer program supervisor. Susan cannot join us today. She was hopeful she could, but again, I'll be sharing some of her content at the very end. We're going to go over a brief history of hospice, a brief history of JSSA, myths and misconceptions of hospice, and then our volunteer program. And by the way, I did let the team know I want this to be a conversation. So if at any point you feel that you have a question or you'd like clarification on something I share, you can feel free to put that in the chat, and in real time, I'd love to answer those questions. We don't have to wait till the end if that's not appropriate. So we can go ahead and keep this as an open dialogue. Love to have a back and forth. So some of you may or may not know how hospice was started or where it started. Cicely Saunders introduced hospice and effective pain management in Great Britain in 1967. So hospice is not a very old program. It's not been around for a very, very long time. It's not something that we haven't even reached the end of our research and our ability to care for people at end of life. So 1967 in Great Britain is when hospice was introduced. And then it was started by her at St. Christopher's Hospice in London. Around 1969 is when Elizabeth Kubler-Ross introduced the 5 stages of grief, which a lot of us are very familiar with. I won't be sharing on that today, but that's around the same time as the first hospice. In the United States, though, we didn't have a hospice program until about 1974 in Connecticut, and that was called the Connecticut Hospice. In 1982, the Medicare hospice benefit was enacted, but service coverage did not start until 1983. In 1985, the benefit expanded and made permanent as an option in the United States. And at the time that hospice first started, a vast majority of patients were diagnosed with cancer. And that's going to be addressed later in my myths and misconceptions. A lot of us, myself included, before I came into hospice, thought that only cancer patients could receive hospice care. And that is not true any longer. It hasn't been for quite some time. So I think with the help of Cicely Saunders as well, even back in that time in 1967, with her help, she recognized that pain management reaches far beyond a cancer diagnosis. Dignity at end of life, compassion, respect, different research that she was a part of showed that it's not just cancer patients. There's lots of patients who can benefit from a well done hospice program. So jumping from the brief history of hospice, and that was very brief, there's lots of other things that go along with the beginnings of hospice in the United States, but moving into who JSSA is. So those of you on the call who do not know what JSSA stands for, it does stand for the Jewish Social Service Agency. That's our acronym though, JSSA. And the reason why we have that acronym is because we want to make it very clear that while our missions and values are rooted in Judaism in that sense, we don't only service Jewish patients. We don't only serve one type of person, ethnicity, religion, background, nothing like that. So that's why JSSA was adapted so that it's well received. We were started in 1893, so way before hospice was started. JSSA was here established in the United States, Hebrew Charities and Hebrew Relief Society of the District of Columbia. The mission was to clothe, feed, and provide shelter for needy Jews, especially immigrants at that time. In 1933, we started focusing on employment for European refugees and for Jewish foster children. In 1967, which is right at the same time that hospice was coming to Great Britain, we actually broke ground on JSSA's current Montrose Road office in Rockville, Maryland. So that's where I was working for the last year and a half. That's primarily where our hospice has been operating in 1984. So what I love about JSSA's history is that we kind of line up perfectly with when we see a need arise, we're the first ones on the scene. 1984, right when the hospice benefit was able to be used in the United States, we said, let's do it. We know we can do it best. We're going to open up our hospice. Jumping down to the very bottom though, in 2026, like I shared in January, JSSA opened the Virginia Hospice branch. So we've been around for about 133 years, and we're very, very proud of the history that we have in this greater Washington area. To clarify, we do service Maryland, DC, not with hospice, but DC with other services JSSA provides, and now in Northern Virginia with hospice. This is our mission statement. I love our mission statement. I think it's really important when I'm looking for an organization I like to work with to look at their mission statement to see if it lines up with my own values and ethics. So our mission at JSSA is to recognize, I'll say it better. The way that it's written is the way it's meant to be read. Recognizing our shared humanity, JSSA empowers individuals and families to enhance well-being across all ages and stages of life. We are guided by Jewish values. We are the partner of choice, providing integrated services that enhance quality of life across our region's diverse communities. So I love our mission statement because it does recognize that we each are worth everyone's time. We each have dignity and deserve respect. And our diversity really sets us apart as well. I'm going to breeze through these just because they have lots of words, and I'm going to share all these slides later. At least your team is going to share them with you. So you can read these later at length. But our core values are 6 core values. The other 2 are on the next slide. Dignity, integrity, hope, inclusiveness, responsibility, and excellence. Now, we've defined each of those words, and I do want you to read back through them at your leisure, but those are our 6 that guide us here at JSSA. So again, I don't want to go too quickly through JSSA's history. If you have any questions, please ask me. I'd be happy to answer. But today we're going to talk about the hospice benefit. That's what I do every day. That's what I love to do. It's what I've done the last 6 years. I hope I never do anything else. It truly is a blessing to work in hospice. And it's such a wonderful benefit if well done. So
Chelsea, we've got a question. Where are
Yes.
you located in Northern Virginia?
Great question. We are off of Haymaker Court. So we're tucked right next to Inova across the street. I'm actually going to share our address at the very end of the presentation. So great question. I will give that to you. So the Medicare benefit. So when we think of Medicare, we also have to think of Medicaid because at this point, while Medicare is our primary payer source, yes, Medicaid services also covers hospice, and most, if not all, private insurances also cover hospice benefits. The question comes to me often, well, I don't have Medicare. Unfortunately, we do have patients who are younger than the Medicare age, 65, but their private insurance will most usually, if they've met their deductible, especially through their treatment options, that their Medicare, the hospice benefit is paid for 100%. Now, my intention with this slide was not to break down every type of insurance and who's covered at what and who has which copay. Of course, as we all know, there's lots of variations on insurance coverage. But this is a brief overview stating that the Medicare benefit does cover all of the hospice services 100%. That includes your intermittent staff visits, medications that are required for comfort, equipment that may be needed for comfort care, and medical supplies. Most of our families find that when entering hospice, that they're ready to stop taking the 15 or 20 meds that they normally are taking, and they're ready to focus on comfort care. So we can stop taking all of our vitamins. We don't have to continue to take our supplements. Those usually are not covered by Medicare, as you can imagine, because it's not the primary reason that they're being brought onto our services. Anything that wouldn't be covered by hospice would be discussed at admission with a nurse who would be meeting at bedside with that patient or family.
Chelsea, is there a time limit to how long Medicare will cover hospice care?
Great question. As long as someone continues to qualify for hospice, that person can stay for as long as needed. What do I mean by that? If someone comes onto hospice with a prognosis of 6 months or less, which is on paper what Medicare is looking for, they have to draw the line somewhere saying that this chronic condition has a prognosis of 6 months or less. If the patient outlives that prognosis because we've well medicated them, or maybe they've stopped going to the hospital as much, maybe their exacerbations are less, and they get to that 6-month line, but they continue to qualify for the chronic disease that they were admitted for, then that Medicare benefit will continue and what we call recertify that patient for ongoing Medicare coverage. So that's all discussed and communicated when a person's on hospice. I know a common other question to follow up that is, well, I have a neighbor who's been on hospice for 2 years, and yet I have another neighbor who was discharged off of hospice after 6 months. What's the difference? Why is this person continuing to have Medicare hospice coverage, and this person was asked, or we were telling them to be discharged off of our services? What ideally happened was that this person over here with the 2 years of coverage continues to qualify for the chronic disease that they may have for hospice services, and there are many criteria. This patient over here may have outlived their prognosis, no longer is showing signs of decline, and actually that's a win. That's a wonderful thing. As far as being a nurse, I love to see that. That patient no longer, though, maybe doesn't want comfort care, and so the goals of care are not aligned, and that person is discharged off of Medicare services. So when we think of hospice too, all of our patients are having to weigh out the difference between going back to the hospital, continuing to see their primary care providers, continuing to see their specialists, and then coming over to hospice. So some people see it as a loss. They say, well, I have these 6 specialists who have seen me and know me and have seen me through this chronic disease for all these years. If what you're saying to me, Chelsea, is that if I come over to hospice, would I give up all of that care to just have hospice? And I put that in quotes. Here's why I put it in quotes. The difference between the models of care is those 6 specialists fall within what's called a multidisciplinary approach. And what we do in hospice is an interdisciplinary approach. So a multidisciplinary approach is used in curative care models, hospitals, long-term care facilities. You have a podiatrist, you have a dermatologist, you have an oncologist, you might have a cardiologist, all of which are wonderful and specialized in each of their fields. But they may not talk to each other per se. They take notes, they share notes, but they're not working together on the same teams. They may even come from different hospital systems. And so that's considered a multidisciplinary approach. The care is directed by the physician through the medical chart. Often we find there's ineffective communication between professions, lack of accountability. One person said, I'll do this. The next discipline said, oh, we can't do that, or I'm not going to do that. And so sometimes we find that there's miscommunication, especially outside of one hospital system. And so while it's a wonderful approach, it usually is in the curative realm. Whereas when we think of an interdisciplinary approach, which is what hospice has, I cannot say that I have a dermatologist and a podiatrist and a cardiologist and an oncologist. That's not true. But what we do have is a nurse, social worker, chaplain, physician, volunteer, hospice aide. They each work together with one holistic approach to the comfort and care of the patient. The team is continually reassessing the patient and family goals, treatment preferences, and support needs. The RN, who's over that team, the interdisciplinary team, is essentially we like to say the patient is in the driver's seat and the nurse is over here in the passenger seat saying, this is where we can go. Is that where you would like to go? So it's definitely more patient-centered and patient-focused than what would be a multidisciplinary approach that's physician-driven or maybe with curative measures in mind.
Can you call in a specialist as needed?
Yes, absolutely. Great question. Because we're limited by what Medicare says our team requires, yes, we call specialists all the time. Right now, we work with a palliative care neurologist, Dr. Daly. I don't know if anyone knows Dr. Daly in the community. She's wonderful. So she herself is a palliative care neurologist specialist, not on our hospice team, but her insight to her patients is invaluable. So our physician and her, they will get on the phone, they will collaborate, and that wouldn't be charged as a visit to that patient. Ideally, we do not want you to end up with a bill at the end of the day, charging both Medicare and an out-of-pocket cost to be able to use that specialist. If anything, we would be collaborating behind the scenes wherever we can with that physician. Okay. As
Can
we kind of,
homeless people access your services? How would somebody
yes.
without a fixed address deal with all the paperwork and recertifications and all that?
Oh, what a great question. The answer is yes. In fact, I myself have cared for an unhoused individual. This was when I was working in San Diego, California. It's a bit problematic when we think of how we set up our visits, right? We want to see our patients at least once a week, if not more than that. That's once a week is our minimum. We don't want to go more than once a week without seeing our patients. So if a person is unhoused and doesn't have structured housing where that we know they're going to be here on a Wednesday every week to be able to see them, that is problematic for a couple of different reasons. Other problem is if we want to prescribe medications, especially controlled medications, if that person has pain, they themselves might be able to have that medication, but we wouldn't want them to get stolen or for that medication to go, missing for any reason because they would need it for their care. It also becomes problematic. I know at least the unhoused person I was working with did have a cell phone, but making sure that cell phone is charged. All of these layers of the care that need to be provided. Our social worker will often work with community resources and of course with the patient to see if they're willing to be placed somewhere or able to be placed somewhere. So we work with our resources and our network, which we have a really great network of providers, assisted living facilities, long-term care facilities that would come alongside that patient and say, what can we do so this patient can receive safe and effective hospice care. The finances, of course, become an issue when you think about, well, that's fine, Chelsea, but if we place them, how are they going to pay for that? We help them through paperwork. We help them through, we'll take them on even as a charity case. We're happy to cover the cost if they don't have insurance and are unable, especially if they're outside of that Medicare range where they're younger than Medicare age. We'd be happy to take that on as a charity case. We just then have to have a very, very specific plan of care moving forward with the psychosocial needs. So that's a very long-winded answer, but I say we take that case by case.
Next question is, do you provide families with guidance on how to navigate hospice care and the Medicare, Medicaid systems?
Absolutely. In fact, in our admission packets, they were sitting right behind me. They're in our other room. There's a Medicare benefit packet that we're asked to give to each of our families, and not just paper to say, read this, good luck, but to have a jumping off point so that we can then facilitate paperwork if they need help filing things, filing paperwork for themselves, if that be the case. Our social worker is more than equipped to do that. I think that perfectly leads into this next hospice circle of care image that I like to share when I talk about hospice and what that looks like. This circle of care is patient-centered. As you can see, the patient is smack dab in the middle. That's what I love about hospice. Being a trained nurse, being in the skilled nursing world, having done nursing in other facilities, I've recognized that not always does the patient get to determine what their plan of care is. They're told what's going to be done to them. And there's reasons for that. There's a place for that. Often I'm, as a patient, not expert in what's going on with me. So I need a physician to teach me or show me. But in hospice, we're at a point where we don't need to seek curative treatments anymore. The patient or the family member, per the advance directive and living will that has been determined by the patient, or per the patient's desired wishes that have verbally been expressed, we can do what's best for them. We surround the patient. They're already surrounded by friends and family. So that's that other circle, concentric circle you see around the patient. And then around that, we truly bring in a circle of care that includes physicians, a registered nurse, more than just one, but a registered nurse for sure is assigned to that patient, a hospice aide if needed, chaplaincy, or spiritual care coordinator is what we like to say nowadays, social worker, music therapists, volunteers, grief counselors. So that's our grief counseling, which is I'm not going to touch on a lot in this presentation, but that extends up to 13 to 15 months after a patient is lost and expired. We will follow that patient for as long as they require grief counseling. We have in-person, phone check-ins. We have lots of versions of that. So I won't get into that today, but it is an excellent benefit to our families once their loved one is lost.
We have a couple of questions about chaplains and music therapy.
Sure.
On the chaplain, do you ask patients about religious affiliations or preferences? How does that work? How do you deal with all the different faiths that might come through your doors?
Absolutely. Medicare asks that we provide for all faiths, all backgrounds. So while we have spiritual care coordinators that are hired on our team that may themselves have one religion that they adhere to, they're asked and tasked with not pressing that religion or converting anyone for any reason, but supporting the religion of the patient and family. So that is usually asked at admission by a nurse saying, do you have a religious preference? Do you practice that religion? Of course, as we know, every religion is very different. Even within the Jewish faith that we even adhere to at JSSA, we know that all Jewish patients practice very differently. And so we want to take note of that, give that to our spiritual care coordinator, and then they usually will reach out to their network of other faiths and other congregations. So we have connections with lots of different congregations in the community, and our spiritual care coordinator will prioritize that and not push any one particular religion.
Okay, and we had a question about the music program. Can you expand on that a little bit?
Yes, so as I shared, we are new in Northern Virginia. We just opened our doors. And so part of my end of my presentation is actually to ask if any volunteers would want to come on with our music therapy. In Maryland right now, we have 4 musicians who are on our team as volunteers. We don't actually have a hired music therapist. So we have a pianist, a cellist, a violinist, and a flautist who is on our team. So those volunteers will go into the community and provide music therapy at whatever level is good for the family. Sometimes that's a one-on-one concert. Sometimes that's our whole family's getting together. Can you come play for his birthday? That's sometimes what it looks like too. Or I mentioned our instrumentalists, like I mentioned the ones who play an instrument, but we also can, of course, bring all types of music with a karaoke machine. We can bring a music player. We can promote that as well. So what part of what my presentation is today is saying we actually don't have a music therapist here in Northern Virginia yet. I am onboarding, I believe, one at this time. Susan, I wish she was here. She could tell you more so that
She's
they can
here.
start. Oh, Susan
She
is
is
here?
here. Yep.
Susan, hi. I didn't see you. I'm so sorry. So if there's a music therapist coming on or someone like a music volunteer, then we'll be able to offer that more readily in Virginia. We can partner with any volunteer that we wish if we had like a relationship in the community where we know that a music therapist. We just choose that all of our volunteers, all of our employees are oriented to the JSSA mission. We take it very seriously that we onboard all of our participants and go through background checks and go through, making sure that they're here for the right reasons so that we don't just send any volunteer into the community so that they represent JSSA well. Okay.
Okay. Do you have bedside singers?
Um, I do
Do.
believe
Yeah, we do.
Susan's
So
here.
with
Hi.
our music therapy, we certainly have. Hi, everybody. I'm Susan. I'm the volunteer supervisor for JSSA. Can everyone hear me?
Yep.
Yes.
Good, good. We do have so music therapy. We certainly have people that are instrumentalists. Unlike some of our other therapies, it's not something that you need to be licensed or professional at. So we have people who play the guitar or the flute or the violin. We have one person that is a professional. Well, most people they have full-time jobs, and this is one of their hobbies. But we also have people who are these beautiful, beautiful singers, and they will come to the bedside or just to visit the person or their family, and we'll find out a little bit about them, what kind of music they like, whether that's from the 30s or the 40s or the 50s, and they'll put together a little repartee of the person's favorite songs, and as a person might get a little bit closer to end of life, they'll sing more like threshold songs, quiet songs. So nowadays, all folks need are a cell phone too, so they might just bring their cell phone and bring some music to the people as well. So we have people that sing, we have people that play all sorts of instruments, and then we also have people that bring their lovely cell phones with them.
Thank you, Susan.
Mm-hmm.
So because Susan's on, I'm going to kind of go a little bit faster because I only took a couple of her slides and melded them into my presentation. But since she's here, I'd love for her to share the extent of her presentation at the very end about how you could get involved or anyone else that you know could get involved as well. So let me move forward to the next. So this is a very brief slide. These are the 4 levels of hospice care. I'm not going to be able to get into all of these levels right now, but and by no means it's a pyramid, but by no means routine level of care that's at the top there. That doesn't represent the amount of those levels of care because routine level of care is actually our biggest level of care. I did not create this image. I apologize. If anything, I wish it was just a square or a rectangle would show you very equally that the 4 levels of care can be provided or should be provided by every hospice that you've ever encountered. Any hospice company that you're thinking of right now that maybe you used for a family member or a friend, they should be, and we are as well, able to provide all 4 levels of these care. Routine level of care is that in-home hospice. It's what you would think of for those who are dying in their home. Continuous care is only indicated with severe symptoms that are unmanaged, that require round-the-clock medications and nursing care. General inpatient care is what you may consider an in-hospital hospice care. Someone who cannot be transported home, who is extremely fragile, who requires that very intense end-of-life care that only can be provided at a hospital level. who may even be intubated. Some of these patients are intubated and cannot return home without hospital level of care. They're put on comfort measures. Most machines are turned off, but we will support them according to their advanced directives. Respite care is that one at the bottom. That is for families of patients who are on usually routine level of care, who may be caring for their loved one around the clock and need a break. They need 5 nights of a break. So what that means is our patients will be transported to a facility that we partner with, and our team will go see them every single day. And while that loved one is away at a wedding or a funeral, or they just want to go on vacation because they haven't gone on vacation with their husband or wife or partner for years and years, and they say, I got to get away. I'm burning out as a caregiver. Respite care is something that is provided with the Medicare benefit and not an out-of-pocket cost for that family. So those are our 4 levels of care. I wanted to get to this next slide before we get into our myths and misconceptions, which is probably Susan and I's our favorite part, because we like to dispel the myths and misconceptions of hospice in the community. So how do you know when hospice is right for you? And I personalize this tab, but by no means think of it as hospice is right for your family member. Hospice is right for your friend, your neighbor, someone you're taking care of. When do I know? There's 2 main things. You must have a terminal diagnosis with a prognosis of 6 months or less. It's often determined by a physician. Now, again, we shared earlier that, well, what if I outlive that prognosis? What if I'm on hospice for 2 years? We see plenty of dementia patients who outlive their prognosis and stay on hospice for a long time. What do you mean by a prognosis of 6 months? Well, a physician isn't going to be able to, with certainty, 100% tell you exactly how many days left you have on this earth. No one has that ability. No one has the ability to look in just one way, black and white terms, and say you have this much time. But we can use our best guess, research-based, evidence-based, to say if the disease runs its normal course without any curative measures, it would not be surprising if this person passes within 6 months or less. That's where that prognosis comes from. Goals of care need to be aligned with hospice goals. Comfort, pain management, no longer seeking treatment or cures, caregiver support, and avoiding hospitalizations. So what we ask, it is a 2-way street. I just showed the circle of care. Patient-centered care is what does the patient want? And if the patient wants to go back to the hospital and the patient wants to go get cures, that's fine. That we will support that. They just can't be on hospice. We really want to support those who are okay and at peace. Now, we can't all be at peace. Even when we think we're at peace, sometimes we say, oh, forgive me, I'm not ready. That's okay. That's what we're here for too. But if a physician has given someone a prognosis, it's often then the fork in the road. Do we want to go back to the hospital, or do we want to stay in home or where I live, wherever that may be? So I just wanted to be brief about this, but also this is obviously multi-layered. So if you have any questions, you can ask me. Absolutely. Some of the common diagnoses for hospice, though, when we think about hospice diagnoses, I mentioned cancer is not the only diagnosis, although it used to be the majority of our cases back in the 1960s, 70s. AIDS, actually our HIV and AIDS patients became a very large part of our hospice population. And no longer, we actually see very few HIV and AIDS cases because of good cures and treatments. So cancer, dementia, pulmonary disease, such as COPD, heart disease, like congestive heart failure, or kidney disease. Those are our top 5. In fact, in our agencies, we find that dementia is probably our number 1. And then heart disease is soon after that. It's actually not cancer, funny enough, for now in JSSA's current state. Okay, so this is our first myth, and I'll try to get through these because I know I've got a certain amount of time. So to give Susan the floor a bit. So first myth, hospice means giving up hope. No, I would very much refute that and say hospice gives hope in new ways. It relieves pain and symptoms that may not have been relieved on curative treatments. It completes personal goals. It's helping someone complete that personal goal, exploring spiritual issues, and finding acceptance and peace. All that can be provided through the hospice benefit. I like to tell a story at this point. where I had a patient who still lives with me to this day. She was 45 years old. She was diagnosed with breast cancer when her baby was about 6 months old. So by the time I met her, that baby, that 6-month-old baby, was now 5 years old. So she'd been living with a breast cancer diagnosis for 5 years. They did all the treatments. They did all the things they needed to do. She's young. She has a small baby. She wants to live. And that made sense. They did treatments. Of course, you have regular PET scans, checkups. And by the time I met her, they had done a PET scan and the cancer had metastasized through her entire body, affecting her lungs and other organs. And there was nothing more that the doctors could do for her. And so I'm meeting her as a nurse for the first time with a prognosis of 1 week. The physician said, you only have 1 week to live. That's all we're going to be able to give you based on what we know. Lots of tears at that admission, as you can imagine, from myself and the patient and her husband and her 5-year-old was not in the room, but from them. And so all she wanted was more life. Give me more time. I just want more time. We admitted her to our services, managed her pain, provided oxygen, equipment that she needed, incontinence supplies, which was a new thing she was dealing with. And she lived for 2 months on our hospice services. And so I tell this story, and I was there when she passed, and it was a beautiful passing. She was able to write letters to her 5-year-old for the day she got married, the day she graduated high school, when she met her first boyfriend, when she this and that, all those things. She was able to set aside clothes and jewelry and things that she wanted her daughter to have when she grew up. That is what hospice did for her. She thought she was given 1 week, and we gave her 2 months. She got to see her ballet recital. She got to go and be pain-free. She got to go into the farmer's market and grab the zucchini that she loves to get every week. That's important to her, and that was important to us. So it's not giving up hope. I say hospice is about death and dying, yes, in one sense, but it's about life and living. And that's what we do here at JSSA, and we do it very well. Hospice means death is imminent. No, actually, we just talked about some people outlive their prognosis, right? So it's not that death is imminent. And when a physician turns to someone and says, I think hospice is now, that doesn't even mean that they're saying they're going to pass within a week or two. That could mean we just don't know how beneficial these treatments and physician visits are anymore. I think you want to focus on comfort. So no, it does not mean death is imminent. Hospice means giving up control. No, actually, control rests with the patient and the family. And when I say in most instances, right, there's some times where someone wants to continue on a tube feeding because they've had tube feedings for many, many years, but the patient is starting to aspirate or starting to choke on that tube feeding. And we would say, when it comes to evidence-based research, evidence is showing us we need to stop those tube feedings because we cannot safely continue to administer those, and our liability goes up, right, as you can imagine. So that's a real-time conversation that we need the family and patient to have with us. It's a hard conversation when you're trying to give up things you've known for many, many years. We recognize that. We have it therapeutically, but sometimes we need to force a hand saying that this is no longer safe for this patient. So that's an instance. Patients must give up their primary doctor to receive hospice services. No, actually, the attending physician is encouraged to remain involved. On our consent pages, I don't have a picture here for you, but at admission, we ask, do you want your primary physician to remain a part of your care? And there's a choice in that. If the patient says, yes, I'd like my primary care who's known me for 25 years to continue to collaborate with your physician, that's fine. We just need to get on the phone with that physician and say, hey, Sally Joe asked for you to be her primary. Are you okay with that? Some physicians will say no, even if they've known that patient for 25 years, because they don't do hospice and they want to default to a hospice specialist, right? That can make sense. But a lot of physicians will say yes, because they've known that patient and they respect that patient's choice. Okay. Once hospice is elected, there is no turning back. A lot of people say this to me. If I sign this paperwork, are you telling me I could never, ever go back to the hospital? No, you are free to leave hospice at any time. It is a choice to come on hospice. It is a choice to come off hospice. If you continue to qualify for hospice after going to the hospital to get whatever that procedure is done that you were wishing to do, You can only come back if you continue to qualify. If that procedure has fixed the thing that we are admitting you for, then you just don't qualify for hospice at that point. But if a good example of this, patients who have cancer sometimes have malignant ascites, where they have the fluid that fills up their bellies. It's very painful, lots of pressure, and maybe the patient doesn't have what's called a Pleurix drain or an Aspira drain or something to drain off the fluid. And so they say, I can't stand it anymore. You guys can't do something for me, which they're right. We are limited by what we can and cannot do in the field. They say, I got to go back to the hospital. I got to get that fluid taken off. That's fine. We probably would discharge off of hospice. It might even require a hospital overnight stay. It depends. Not always, but it depends. But then that patient still has cancer. It's still terminal cancer. So we're happy to readmit that patient back into our services. They meet the they meet the criteria for hospice. Okay. Again, I'm blowing through these really quickly because I know our time is limited. Hospice is only for cancer patients. I already addressed this, but less than 20% of our hospice patients actually have cancer. So other diagnoses is usually what we see. Hospice patients must have a DNR order. That is a big myth. We actually admit people all the time that have what's called a full code or perform CPR order. So it's not true that you have to have a DNR order. Is it best? Probably, right? Because we're at the end of life, meaning that we all have to come to the grips with the idea that this is going to end sometime. It's very painful for CPR to occur. I myself have performed CPR as an EMT when I was on ambulances. It is very painful, and the likelihood of coming back to a full baseline is less likely with someone with a terminal diagnosis. So we explain that in a medical way, but still it is the patient's right to choose whichever path they want. We just would have to call 911 when that patient does pass so that we would honor their wishes with a full code order. Okay. Morphine hastens death. Morphine is a big medication, one of those that people are afraid of when I mention it at admission, saying, I don't want morphine. I don't want them to be sedated. The good news is that we give morphine at very low doses, and it's titrated for comfort. We give 5 milligram doses, which is what we give NICU babies, those in the hospital. So it's very safe doses. And our intention is not to sedate or to hasten death. Morphine helps when someone has air hunger or is at the very end of their life. It really helps to relax the body so that everyone is comfortable. All that education comes with the admission to hospice, but that is actually a myth. It does not hasten death. If anything, it brings more comfort. We have patients who've been on morphine for many weeks and they have not passed. And it's very helpful for them, and they can actually walk around the house and feel comfortable. I'm gonna kind of blow through these so I can give it back to Susan, I think, because in Northern Virginia, we have a higher, faster adoption of hospice services compared to rural areas of the state, like in this Northern Virginia area. So we find that we utilize the hospice benefit a lot more. And our average length of stay right now is about 18 days in Northern Virginia. That's not a lot of time. So even then we're talking about, well, can you outlive? Yes, you can outlive your prognosis, but a lot of our patients are waiting till the very, very end until they choose hospice. We would say, come to us first and see, could you provide comfort for me for a long period of time so I don't have to go back to the hospital? Yes is the answer, as long as you qualify. Don't wait till the end because it's very rushed. And then you're meeting a bunch of team members and you're signing consent papers and everyone's a little bit scared and frantic. We try to bring as much peace into that situation as possible, but it's inevitable if we wait to the very end. We always have a comprehensive assessment at the beginning of care. We always do final days visits. So we actually just had a patient pass on our services yesterday, and we identified her need for a daily visit from a nurse. And we identified that on Friday, and she received a visit every single day. One day was twice a day to make sure that she was comfortable until the very end. And she died very peacefully, very comfortably. We were very proud of the work we were able to do for that family, and they felt extremely supported by our team. So we exceed national averages in Northern Virginia, and JSSA does as well. So these slides will be given to you. Before I move it over to volunteering, you're going to get these slides. But why choose JSSA? Why is JSSA the hospice you want? We serve families of all faiths and backgrounds. We are a nonprofit trusted community partner and have been, like I shared, for 133 years. I think that speaks for itself, but truly we are well established and we are well connected. So you'll have a network of support. We exceed national averages in number of visits made during final days, and we have a low rehospitalization rate, which the hospitals love us for, not just the families. The hospitals are saying, good, we don't need rehospitalizations. That's just too much for everybody, much less the patient who would be distressed. We are specially trained. As I shared, I have my certification in hospice and palliative care. I work alongside many who have their doctorate, who are specialized in palliative care, death doulas, who then, that was previous when they used to do that. They don't do it with JSSA, but they have that in their background. People who are specialized in what we do. That's who JSSA hires and has on staff. About 80% of our patients and families receive or accept support from our spiritual care coordinators. 80%. If you go to another hospice, it's probably down to about 30, 40% that are accepting of a spiritual care coordinator. The way that we approach our spiritual care is not with one faith in mind. It is saying, let us come and circle you, come around you, and support you. And we find that we have a very high acceptance rate, and that is a better outcome for the patients and families. We do have a We Honor Veterans program, which Susan can touch on next. And it is wonderful. We have pinnings, flag ceremonies. We do it posthumously. We do it when the patient is alive. We do it at whatever level they wish. If they want a private ceremony, if they want a public ceremony, if they want it on Veterans Day, Memorial Day, whatever it is for them, we make it work because we really care and we are so proud of our veterans. My husband is a veteran. He served in the Marine Corps. So I would want the same services to be provided to me when that time comes. And lastly, here in Virginia, we do support after hours admissions. That is not true of any of our competitors at this point. I can say that with 100% certainty. If you call JSSA after hours, which would be around 5 o'clock, you can get someone on the phone and we are happy to do an admission for anyone who may need it after hours. Okay.
Okay, just so you both know, we're at 10 minutes to 11. So
Okay. Susan, I truncated your slides if you want to just speak off of these, if that's okay. I didn't mean to cut it. I just needed to cut it for my purposes. But if you wanted to just present about our different types of volunteers, I'm happy to walk through these slides.
We get and there that's fine. There's a couple questions in the chat, Chelsea, if you wanted to
Okay.
respond to them. I wasn't able to respond to them fully. So JSSA Hospice volunteers, I don't know if Chelsea mentioned this or not, are required by Medicare. So hospice was founded by volunteers. So when that benefit was codified, they wrote hospice volunteers into that codification. So 5% of our clinical hours, so for every hour that our nurse, our social worker, our chaplains, our aides are there, 5% of those have to be volunteer hours. And for that reason, our volunteers are treated very similarly to our staff people. They go through the same background check, reference check, TB check, flu shot. Our volunteers, Medicare requests that we do about 16 hours of onboarding training. And so ours, when it's all said and done, our volunteers go through about that many hours for their training. And it's almost all exclusively online. We start off with a 45-minute interview in the beginning just to chat, get to know you. It's all very individualized. And at the end of your onboarding, we do that chat again just to make sure you're where you want to be and that you feel fully supported. And then the rest of it in between is all online training. And our staff here is happy to chat with you at any point during the process. Some people will blow through the trainings in a week. Some people will start the trainings, come back a month later, 3 months later, because something might come up, and finish that onboarding training there. So for the most part, it is about a 16 hours total of training, and that's a mix of in-person interviewing, and then we do a 2 to 3 hour training at the end just to bring people together. You meet other volunteers, we answer any questions, we go over any questions that have come up. We talk about caregiving and HIPAA again, safety precautions, things like that. So that's our last phase of our training, our phase 3 training. And that's in person for about 2 to 3 hours. You guys probably want to know, I don't know if there's other slides that you want to
Yep.
go to, Chelsea,
I have the
but
different.
I can talk about.
I have the
Perfect.
different types of volunteers, and that's
Perfect.
it's about 5 more slides, and then we would be wrapping up.
Perfect. Perfect. So, most of our volunteers are what we call, these are our in-person volunteers. They're called companion volunteers. They can read, and somebody asked this in the chat earlier, if someone's bedbound, what can you do? Our volunteers can do a lot of things. They're especially trained to do a lot of things. As mostly we try to find as much about the patient as we can so that we're able to really make the best use of that 1 hour, 45 minutes, however much time there are people read. We talked about playing music. They could sit there offering the supportive presence, even though someone might not be conscious, they still know that someone's there. They hold their hand, they play quiet music. It's just really being that person that's there for them, even though they're not able to communicate any longer in words. It's just being there for them. They might share pictures or videos. If they know that the person particularly likes cats or dogs, they might share little cute cat videos or dog videos. If they have the capacity to do painting or crafts, they can do that with them. Or they have the capacity to go to their activities room, they might go to the activities with them. There's a million different ways that our companion volunteers interact with the patients. Most of our patients, and I'm speaking just from Maryville, most of our patients do have some sort of dementia diagnosis. About 60 to 70%. It might not be the diagnosis that brings them into hospice, but it is something that we do have training with volunteers with, so they're able to interact a little bit more with those persons with dementia. We do respite volunteers. So maybe, you're the primary caregiver for your spouse, and you just need to take a break. You need to go to the grocery, you need to take a walk, you need to do whatever you need to do for a couple hours. We could have volunteers that come just sit with your person for a couple of hours. Our volunteers cannot do any direct care. They can't feed or bathe or do any of those things. That's what our aides do. But they can sit there, they can read, they can do any of these things with them. They can, so that person can just be there, right? We did have a volunteer that would sit with the patient's spouse while the spouse was literally there in the next room. They just needed to know for 2 hours that their person was okay. So that's just a regular respite. Our vigil volunteers are for people who are very actively dying, and that's an extra training for people. Once you volunteer for 6 months, we give an extra training about what does it mean to be imminently dying and what do you need to be prepared for, things like that. And that's the same. If a caregiver, a daughter, for example, is living with mom or living in a facility, she doesn't want mom to be alone during those hours that she's dying. So we can send a series of volunteers to sit with them as they're dying so they're not
Right.
necessarily alone.
I'm so sorry.
Um,
I
yeah.
was moving into the specialized volunteers. I hope that's okay. I didn't
Yeah.
mean to
Yeah,
give you
yeah,
a
yeah.
vision.
So music volunteers, we talked about Reiki volunteers, massage therapists and Reiki volunteers, and healing touch volunteers. That does need a special certification. We don't have a lot of massage therapist volunteers. Like I said, they have to be certified, they have to be licensed, and they have to be specially trained to deal with people who are usually very frail. We do have Reiki volunteers. For those of you that aren't familiar, it's a more of a healing touch. There's Reiki centers that train these people to do like non-touch healing, energy healing, and a lot of our patients, especially our cancer patients, really feel better after these Reiki sessions. We have probably about 6 people now in Montgomery County that are trained as Reiki volunteers, and happy to talk to anyone individually about what that means. And if you are a Reiki volunteer, it's an amazing way to give that gift to folks.
I didn't put their names on them because Susan has their names, and there's so many others I can think of, but these are some of our pet volunteers.
So these are our pet volunteers. On your far
Yeah.
left, that's Coda. He's a 170-pound lion poodle, something like that. He's amazing. In the center there is Ethan. He's our therapy bunny. So all of these animals are not just they're licensed therapy pets. So they go through all of the training. Even Ethan went through all the training to be a therapy pet. So we have all of their vaccination records. We have their certification. There's different organizations that will certify your pet, and some of them will even certify your rabbit or your cat if you'd like.
Okay. We have 2 more.
Um,
Sorry.
Tuck and call. So these are more of our virtual opportunities. If you find that maybe you're not able to go out and do regular visits, but you have an hour or a half an hour on a Thursday afternoon. We have volunteers that make tuck and callers. So when people come first on hospice, they might be super overwhelmed. They come in, they have this the admission nurse comes in and says, these are the 8,000 things the hospice can do for you. And they are like, wait, what? Okay. So this is a way for them to call, just to remind them that Jess is there. Make sure they need any medications, any supplies, any concerns, any questions for the team. Our volunteers call just to check them in, tuck them in when they can, make sure they have something, everything that they need. And that's a little additional training after you're onboarded, fully as a volunteer. Indirect office support. You come in, make packages. If you happen to be in the Rockville, Maryland area on a Thursday afternoon, we do have Flower Day, where you can come in and help arrange flowers. Bereavement, we do mailings, cards. We help at the front desk, so our volunteers can do a lot of things that aren't patient to patient. So we're always happy, and those hours count too. So all of the hours, regardless if they're in person, or whether that they're virtual or they're in the physical office, they count towards our 5%.
So one thing I did not include, and truly it was just me adding in the slides, was, like I said, our We Honor Veterans volunteering. That if you are yourself a veteran or wish to help with Susan's team and her awesome veterans, we do pinnings all the time for our veterans. We actually have 4 on our services right now in Northern Virginia, so we're looking to do those very soon. So I know we're at the very end of our time. That's a full hour. We so appreciate your time, but someone asked me for this address and for this phone number. Don't fret. Susan and I work in 2 different branches. So if she needed to be contacted, if she primarily works in Montgomery, that's not to say that I don't have complete access to Susan, and vice versa. So we can reach out to each other, have questions, and I'd be happy to forward our information, both of our information, to this team in our email thread with you, Liz, and your team, and we can forward that out to you. So you can get our main numbers in both our Maryland branch and in our Northern Virginia branch. Any questions? I'm trying to answer them in the chat.
I have a couple of questions. One is, do the music volunteers get any special training, or do they audition? How does that work?
We just take their word on it that they are that they have the ability to. They go through the same training as all of our volunteers do. We just say if they play the cello, they'll tell me, "Oh, I'm not a professional." I think that's okay. We just sort of we don't make them audition. To do actual music therapy visits, you do have to be certified, but we, not our musicians. We do have a couple people who are certified music therapy, but they're not. If you play the guitar well enough for your grandson, then you
Yeah.
we just take your word on it that you have a beautiful singing voice, or that you have, even though you're not a professional.
And Chelsea, you mentioned pinnings a couple of times related to veterans. What is that?
Yeah. Susan can actually give you her quick spiel, and I'm going to pull out some pins. I'll show you what we mean physically.
Yeah. So our we have veteran volunteers usually, and it's usually either coordinated by our chaplain or our social worker. But we'll find out the name and rank of the person. We'll make a certificate for them. We'll give them an American flag pin and an actual flag. Our volunteers do quilt red, white, and blue blankets for them as well. And we'll do a little ceremony. And that star is a piece of an American flag that's been since retired. So we'll give them a star and an American flag. We have a ceremony that we have scripted just to honor those persons at the end of their lives. And that's regardless of their capacity. If they want to be honored as a veteran, sometimes it's just for the family. And sometimes the person's very aware and alert and very proud of their military service and very proud to participate in that ceremony.
Okay, well, we're a little past 11 and I don't see any additional questions. So I think I can speak for everybody and say that we learned an awful lot here. This was a very excellent, informative presentation.
Good.
And so thank you for taking the time to talk to us.
Absolutely.
And I'll remind everybody, next week we are hearing about driver safety and mobility as we age, which is a topic of interest to pretty much everybody, I expect. And with that, I'll say I hope everybody gets a chance to get outside, enjoy our relatively warm weather today.
Yes.
Yes.
So nice to meet
Thank
you all.
And reach out if you have any further questions, anything, reach out. You can reach us through email or phone.